The knee is often called the easiest joint to interpret in MSK MRI, but most junior radiologists overcall normal findings, lack confidence, and even miss common pathologies. Structures like the posterior lateral corner, menisci, and ligaments have nuanced anatomy, so it's easy to second guess what's normal. That is why we created this video, your ultimate guide to interpreting knee MRI, led by Dr. Angela Atinga, one of the best MSK radiologist teachers I've ever met. She trained at Cambridge, Imperial College in London, completed 2 MSK fellowships in Toronto, and has won many teaching awards for her clear, structured approach. In this video, after a quick orientation to routine sequences, Angela will take you through her step-by-step approach, including a detailed look at anatomy, what normal looks like, and exactly what to look for in each structure. This concise yet comprehensive review compresses years of knowledge into one practical video. I wish I had this when I was a resident. It would have saved me a lot of time. Still, the single best way to learn radiology is by seeing real-life cases. But in real life, most cases don't have much learning value, so it takes years to learn what you need to know. In contrast, our Knee MRI course on navigatingradiology.com includes a curated list of fully scrollable real-world cases, handpicked to teach you all of the key concepts in the most efficient way possible. We gamify radiology by giving you AI-generated hints and feedback, interactive links to key findings, concise teaching points, and video answers. To access this course or one of our other courses in basic CT, neuro-MRI, or body MRI, go to navigatingradiology.com. For this talk, you can follow along with the same knee MRI Angela is using by scanning this QR code for instant access. But even better, use the link in the description to get the fully labeled version, including links to all of the key anatomic structures, for free when you sign up on our platform. So, without further ado, I'll hand things off to Dr. Angela Atinga. Enjoy.
The sequences for routine knee MRI differ depending on the institution, but will include sequences in axial, sagittal, and coronal imaging planes. Where I work, our routine knee MRI protocol includes coronal and axial protein density fat suppressed sequences, a sagittal T2 weighted fat suppressed sequence, a sagittal PD non-fat suppressed sequence. Before we get into the detailed anatomy and approach to knee MRI, let's go through each of these sequences to understand what normal signal looks like. On the protein density sequences, we have good distinction between the cortex, the bone marrow, cartilage, and joint fluid. The signal from fat depends on whether or not there is fat suppression. So let's bring up this other sequence here. You can see here on this coronal image and on the previous axial image, those are protein density fat suppressed sequences, and the signal from subcutaneous and bone marrow fat has been nullified. This will make any edema in the bone or any fluid in the joint stand out. In contrast, here's a non-fat suppressed sequence where the fat remains of bright signal. So you can see here there's bright signal in the bone marrow as well as in the subcutaneous and popliteal fat. The key thing to remember here is that on protein density sequences, fluid will be bright throughout. So even though this can mimic a T1, you can see here that fluid is bright, whereas in a T1 sequence, the fluid would be dark and the bone marrow would be bright. PD sequences provide high spatial resolution and soft tissue contrast, which is why this is really a workhorse in knee MRI and MSK MR imaging in general. The other sequence we utilize is the T2 weighted fat suppressed sequence. And again here you can see that the fat has been nullified, so the bone marrow signal will be dark and fluid signal again will be bright. Although you have similar distinction between the cortex, the bone marrow, cartilage, and joint fluid, the contrast resolution between the different types of tissue is slightly lower than on the protein density sequences. Another key difference between the protein density and T2 weighted fat saturated images relates to the so-called magic angle artifact. So we'll hear about this a lot in MSK MR imaging. Magic angle artifact refers to artificially increased signal intensity in curved structures made of tightly bound collagen. These collagen structures are normally of dark signal intensity on all sequences, but when curved and oriented at approximately 54.7 degrees to the main magnetic field, they can show artificially bright signal on short time echo sequences, specifically protein density and T1 weighted sequences. So two common locations where you might see magic angle artifact are at the patella tendon near its tibial or patella insertion and in the proximal aspect of the posterior cruciate ligament. So this is a protein density sequence and this is a T2 weighted fat suppressed sequence. When you're thinking about magic angle artifact, you'll be looking, for example, here at the proximal patella tendon insertion, and you can see that that signal is bright. The key thing to note here is that on the T2 weighted sequence, you don't see that bright signal here. So if you're questioning an error of high signal on the protein density images, you can always use the T2 weighted sequence to tell you if it's real or not. Rarely we'll utilize a stir sequence, which is another type of fluid sensitive sequence. We can use this in a few select situations, for example, when the patients have hardware in place that causes artifact. The stir sequence is less sensitive to metal artifact and therefore you'll have more equal fat suppression. The downside of the stir sequences is that they have lower spatial resolution than the standard T2 weighted or PD sequences, so we tend not to use them routinely. Some institutions will also require a T1 weighted sequence in one of the imaging planes to better assess the bones. On T1, normal fatty marrow, bone marrow will be bright. So here you can see that the bone marrow will be bright. And so any bone marrow placing lesions will be of dark or low signal intensity in comparison. The difference is that on T1, the cortex, cartilage, and joint fluid will be of low or dark signal, which is different to what you see with the PD weighted sequence here, where this area here of joint fluid, which we can see here on the T2 weighted sequence, is bright. So in PD, fluid will be bright, on T1, fluid will be dark. There's some other special sequences that we use less frequently, which will be discussed later as we go through the case-based course. Okay, now that we've covered the basic sequences, let's move on to think about anatomy and our approach to a knee MRI. I utilize a modified inside-out approach when reviewing the knee MRI, and I'll be looking at the structures in the following order. First, I look at the menisci, then the ligaments, including the ACL, the PCL, the MCL, and the lateral collateral ligament complex, along with the posterolateral and posteromedial corner structures. I'll then look at the extensor mechanism. I'll look at bone and cartilage, joint fluid and synovium, and finally, the rest of the soft tissue structures, including the popliteal fossa, the fat pads and bursae, thinking about the neurovascular structures and the muscles. So let's go through each of these in order. For each structure, we'll cover the normal anatomy and MRI. I'll describe some pathology, but don't worry too much about that for now. We'll cover that in more detail in the course. The menisci are C-shaped structures between the femur and tibia, which function as shock absorbers to provide increased stability and even weight distribution in the joint. The medial meniscus is larger than the lateral meniscus. It has a more open-shaped C-face configuration as opposed to the lateral meniscus here, which is more tightly bound, mimicking an incomplete ring shape. So again, here's that medial meniscus with an open C-shaped configuration versus the lateral meniscus, which has a more closed-shaped C configuration. The posterior horn of the medial meniscus tends to be larger than the anterior horn, whereas if we move on to the lateral side, the anterior and posterior horns are of similar size. The menisci are comprised of tightly bound, highly organized collagen fibers. These can be arranged in a longitudinal fashion extending from front to back, as well as in a radial fashion extending from inside to out. So your longitudinal fibers will run in this way and your radial fibers will run in this direction. This organization means that a normal meniscus will have very tightly, highly organized collagen and therefore will be of low signal intensity or of dark signal intensity in all sequences. Sometimes we see linear intermediate signal at the periphery of the meniscus. For example, in this case, you can see this faint gray line that doesn't touch the cartilage surfaces here and is really confined to the periphery of the meniscus. This is related to a small vessel and is a normal finding, not a tear. On the other hand, meniscal tears will be a fluid signal, usually a bright white line that extends to the articular cartilage or the articular surface. We need to see this bright fluid signal on at least two sequences or two slices, even if these are in different sequences. Meniscal tears can be classified based on their direction. So if you bring up the axial images again here, tears can be longitudinal, extending from the front to the back. The longitudinal tears can happen in a vertical direction, that's top to bottom, or in a horizontal direction, that is through the body of the meniscus in this direction. And then finally, we have radial tears, which tend to occur from the center going towards the periphery. So what will tend to happen is that you'll have blunting of the edge of the meniscus, which progresses along the meniscus as you're going from in to out, and that will be called a radial tear. It's really important to assess each meniscus in its entirety, from the anterior root to the posterior root in every imaging plane, just to ensure that you don't miss a root tear or a bucket-handle tear. So in this case, for example, here, we'll look at the medial meniscus. We're right at the back of the knee here. You can see the popliteal vessels. This is the posterior horn of the medial meniscus and the posterior horn of the lateral meniscus. As we scroll through these, we're going to come into the body of the meniscus here. So we've gone to the back of one edge of the C here. We're going into the curved bit of the C here on both menisci. And we're going to keep scrolling through until we come into the anterior horn. So that's the anterior horn of the medial meniscus, and that is the anterior horn of the lateral meniscus. I'm just going to scroll through again, both of them from front to back, so you appreciate that. So we've gone from the anterior horn, we're now with the body, and we're going to keep scrolling until we come to the posterior horn and the posterior root attachments. We need to do this on all three imaging planes. So again, this is the back of the knee. If we're looking here at the lateral meniscus, this is the posterior horn. We're going to follow that to the posterior root attachment. Let's come back again towards the periphery. This is the rest of the body of the meniscus. And now we're coming into the anterior horn to the anterior root attachment. One thing to note here on the sagittal sequence is if you're out here at the periphery of the meniscus, you need to see a complete contour of the meniscus all the way from front to back with no gap on it on at least two sequential slices. So right at the periphery, there's one slice, there's a second slice, and then if you move on to the third slice, you'll start to see this shape forming. If you don't see that complete meniscus in at least two slices from the periphery, you should be concerned about a type of meniscal tear which has displaced meniscal tissue, in particular a bucket-handle tear. With practice, you'll be able to appreciate the menisci really well on the axial images, so it's good to make sure that we practice that. So here's the lateral meniscus, and here's the medial meniscus. This is a particularly good sequence when you're thinking about the radial tears that I described earlier, and additional tears such as a parrot beak or a flap tear that can happen on this inner margin. So we'll show you some examples of those as we go through the course. In some individuals, you can see some small ligaments which connect the lateral and medial menisci. The most frequently seen is the anterior transverse meniscal ligament, which you'll usually see between the anterior horn of the lateral meniscus, the small structure here, and as you follow it across will connect towards the anterior horn of the medial meniscus. There are also some ligaments called the meniscofemoral ligaments, which connect the posterior horn of the lateral meniscus to the femur. So these are the meniscofemoral ligaments, and they're usually anterior and posterior to the PCL. We'll go through those in a little bit more detail in the next section. The reason I mentioned these additional ligaments, or these anatomical variants, is that the clefts between these structures and the menisci can mimic tears. So you have to be aware that they exist in order to look carefully and decide if it's a normal anatomical variant versus a tear. Let's move on to think about the cruciate ligaments. The anterior cruciate ligament is made up of two bundles, an anteromedial bundle which attaches to the roof of the intercondylar notch, and a posterolateral bundle which attaches to the wall of the intercondylar notch. I'll show you these in the axial images shortly. These two bundles show differential tension depending on knee position and extension or flexion. The ACL fibers are also not tightly bound, so you can see that there are these areas of intermediate signal, sort of gray signal in between the fibers of the ACL. These are interdigitating bits of fat, and they give the ACL this striped or striated appearance. This is normal and is not an ACL tear. In contrast, an ACL tear will show fluid bright signal between the fibers. You might see thickening of the fibers or loss of tension, or you might actually see complete discontinuity. So I just want to show you again, here's the ACL on the sagittal images, and you want to scroll through the entire ligament. You can also see it here on the non-fat saturated protein density sequence. And as I said, remember this striated appearance is normal. So let's look at the coronal sequences in reference. As we scroll through, you can see that that's the ACL. That's going to correspond to this striated structure here, which is attaching to the lateral wall of the intercondylar notch. The structure attaching more superiorly is going to be the anteromedial bundle, and this structure attaching more laterally is going to be the posterolateral bundle. You can also see the ACL nicely on the axial images. So if we come down to the tibial footplate here, the ACL is going to be sitting more anteriorly. So we're going to follow this structure, and as we follow it up through the intercondylar notch, it's going to come and attach onto the lateral wall. So remember, the structure attaching more laterally is going to be the posterolateral bundle. Sorry, that's the posterolateral bundle there. And the structure attaching more superiorly is going to be the anteromedial bundle. So again, this is the ACL here. Look how broad that footprint is, and you get followed through the intercondylar notch back to the anterior tibia. Unlike the ACL, the PCL is formed of very tightly bound collagen fibers, and therefore we expect it to be of uniformly low signal intensity in all sequences. The unique caveat to this is that the PCL also can show magic angle artifact, particularly when you're looking at these proximal fibers here before the genu. In some individuals, you might see the meniscofemoral ligaments that I described before. So you can see here is a PCL which has this coma-shaped appearance, and you can see this rounded structure which is sitting anteriorly, and then you can see a more oval-shaped structure sitting posteriorly. These are the meniscofemoral ligaments. The anterior ligament is the ligament of Humphrey attaching to the femur and the posterior horn of the lateral meniscus here. And here posteriorly we have the ligament of Risberg, that's Risberg with a W, connecting the posterior horn of the lateral meniscus to the femur. And again, we just want to show you these structures and emphasize their existence because you can easily misinterpret this for a tear even though they're a normal variant. Just like the ACL, we must practice looking at the PCL in both the coronal and axial planes. So if you come to the posterior aspect of the tibia down here, this is the PCL footplate. We're going to follow this structure superiorly as it goes to attach to the medial aspect of the femur at the intercondylar notch. So ACL anteriorly, PCL or posterior cruciate ligament posteriorly. On the coronal images, we've already shown you what the ACL looks like. So on the other side here, this very low signal intensity structure here is going to be the PCL, which is going to extend to the posterior aspect of the tibia. PCL tears usually present differently to an ACL tear. It's quite rare to see complete discontinuity of the ligament, but what you might see is increased fluid signal intensity within the substance of the ligament or thickening. Even though you don't have disruption of the fibers, we will classify that as a tear, whereas there's some variance in the ACL, so we don't always call everything we see fluid-wise in the ACL a tear. It might be something like a mucoid degeneration, whereas in the PCL, you have a much lower threshold for calling a tear if you see signal intensity within the substance of the ligament, even though the contour is normal. And we'll show you some examples of that in the course. Okay, so let's now move on to think about the collateral ligaments. On the medial side of the knee, we have the medial collateral ligament. This is formed of a deep, thin meniscofemoral component which extends from the femur to the meniscus, and a meniscotibial component which is this thin structure here extending from the meniscus to the tibia. Superficial to those, you have the thick band of the superficial MCL extending from the medial femoral condyle to its attachment here on the proximal tibial diaphysis. Often the distal end of the attachment is not included in the field of view, so it's really important for you to assess the tension in the ligament throughout if you're thinking about a surrogate marker for a tear. On the axial images, you can also see the MCL nicely here, so I'm just going to take off that reference line here. So we're at the medial side of the knee, and this low signal intensity thick band structure here is a superficial component of the MCL, so you can follow that down from the medial femur as we head down towards the tibia, and then you start to see its insertion there. So on the axial images, you will often see that distal insertion a little bit better. MCL injuries can be classified as low grade, where there's edema surrounding the ligament, but it otherwise looks normal. Moderate grade, where the ligament itself is thickened and the fibers may be of abnormal signal intensity, but they remain in continuity. And then finally, you have a high grade tear where there is disruption of the fibers and loss of that tension that we were talking about. There are additional structures at the posterior medial corner of the knee that contribute to stability. The main ones we will focus on are the semimembranosus tendon, the medial gastrocnemius, and pes anserine tendons. This is a classic exam question, and so we'll probably go through these in a bit more detail. There are smaller structures like the posterior oblique and oblique popliteal ligaments that are beyond the scope of this introductory lecture. So the semimembranosus tendon, which is this broad fan-like structure here, will descend to attach onto the posterior medial aspect of the tibia, and again you can see how broad that insertion is. It has a fan-like 5-point attachment to the back of the tibia. All you need to know is that this broad appearance with this interdigitating fat here is a normal appearance of the semimembranosus tendon. Immediately adjacent to that is this other curvilinear structure here, which is a different tendon, as you can see between them. This is the tendon of the medial gastrocnemius muscle. And this is a really important anatomical landmark because if you see a cyst or a fluid collection that extends between these two structures, that is a Baker's cyst. So this is the anatomical location in which you'll be looking for a Baker's cyst. There are also these three tendons at the medial aspect of the knee, which together are called the pairs-anserine tendons. So if you follow them up from the medial thigh, this is the sartorius muscle, and this will be the sartorius tendon. Immediately posterior to that, this rounded structure here will be the gracilis tendon, and then the most posterior small rounded structure here will be the semitendinosus tendon. And there's a mnemonic for this which says say grace before T, so sartorius, gracilis, and semitendinosus. This group of tendons is important because they can be torn if you've had an injury. You can get inflammation around them or a fluid collection or bursa that can cause medial-sided knee pain. They're also useful to routinely assess the tendons, as these can be harvested for hamstring ACL graft reconstructions. So while we're on the axial images here, we're going to move on to think about the posterolateral corner, which is also another area that trainees occasionally find challenging. The posterolateral corner is made up of many structures, the most important being the distal biceps femoris tendon, the fibula or lateral collateral ligament or LCL, and the popliteus tendon. There are smaller structures such as the fibula, popliteal fibula, and arcuate ligaments, but these are beyond the scope of this introductory lecture. So what I'll try and do here is show you these three structures on all the three imaging planes, just focusing on the fluid-sensitive sequences. Okay, so here's the fibula head, and for the fibula head, we can see that there's a structure here which is attaching onto the bone. As we follow the structure more proximally at the lateral aspect of the knee, you can see this band of tissue here, which is going to attach onto the lateral femoral condyle. That is a fibula collateral or lateral collateral ligament. Immediately posterior to that is the biceps femoris tendon, so we're going to follow this more posterior structure here as we extend proximally into the thigh. You're going to see these two bands of tissue which come together, forming a single structure here. That is the distal biceps femoris tendon, and here is the muscle. So just to show you that again, this is a muscle with the biceps femoris tendon. We're going to descend down towards the fibula head, and you can see that they have that split attachment. That's a normal finding. Often the lateral collateral ligament here will attach to the fibula head between these two slips. You can see the same anatomy here. So here's the fibula head, and if we look, the structure which extends from a muscle belly down here, this is going to be the biceps femoris tendon. And if you scroll through a little bit more, you can see this vague outline here of the fibula collateral ligament if you think about partial voluming. So this V-shaped anatomy here is a normal appearance of the conjoint tendon, which is made up of the biceps femoris and fibula collateral ligaments. On the coronal images, again, you'll see that here. So we have to scroll through a little bit just because of partial voluming artifacts. But here is the proximal margin of the lateral collateral ligament. And then as you scroll through, it's going to have this slightly curved orientation as it extends towards the fibula head. And more laterally here, you've got the biceps femoris tendon, which is extending from the biceps femoris muscle. So that is the normal appearance of the conjoint tendon. You can sometimes see these areas of intermediate signal or interdigitating fat at the tendon. That is normal and should not be confused for a tear. Like the MCL, a tear will present with either periligamentous edema if it's a low-grade injury, maybe thickening of the conjoint tendon structures or intersubstance fluid in a partial tear, or complete disruption of the structures. The third main component of the lateral collateral ligament complex or posterolateral corner is going to be the popliteus tendon. So the popliteus muscle belly forms part of the deep posterior compartment musculature, and you can see it here rising from the tibia. And then this is a muscle belly here, and centrally here we have the tendon. So now we're in the proximal third of the calf and we're going to head back towards the knee, following this structure here, which is a popliteal tendon. You can see that it's starting to curve laterally around the knee, and it's going to attach onto the lateral aspect of the distal femur or the lateral femoral condyle. I'm just going to try and orient you here. So this is the muscle belly we're interested in here. You can see it right up against, arising from that posterior margin of the proximal tibia. So this is the proximal tibia here. This is going to be the muscle belly here. So that's just to orient you. So here's the muscle belly. This is the tendon centrally within it. As we follow this tendon, it's curving around the posterolateral aspect of the knee. This is a tendon again here, and it's going to attach onto the lateral femoral condyle. We don't see that attachment as well on the sagittal images, but we can certainly see it here on the coronal images. So here's the muscle belly. This structure here is a popliteal tendon, which is curving around the posterolateral aspect of the knee. This is still the tendon here, and then it's attaching onto the lateral femoral condyle. You can see that this tendon looks different to all the other structures I've shown you here. There's this area here which looks of high signal intensity, and you might wonder if that is a tear. But I just want you to appreciate that this is a curved structure, so it's curving around the posterior aspect of the knee in relation to the magnetic field. So here's another example of that magic angle artifact that I mentioned to you. And the popliteal tendon can be challenging because you do see that magic angle artifact on most planes of imaging, just because of its orientation as a curved structure in all three planes. The only plane that wouldn't be affected, or the only sequence that wouldn't be affected, is this T2 weighted sequence. But of course, we're in plane with the tendon, so it can be very difficult to see it. So if you try and follow this tendon up here, you can see here it's still dark signal intensity, but then here you get partial voluming and it blends in. So just to remind you that magic angle artifact means that you should have a higher threshold for calling a popliteal tendon tear. You want to see edema that is extending towards the muscle belly. You want to see irregularity of a wavy appearance to the tendon before you call it a tear, just based on the signal characteristics alone. The last structures of the posterolateral corner that I'm going to mention will be the lateral gastrocnemius muscle and the lateral gastrocnemius tendon. Anteriorly, you have the iliotibial band, which is this structure here that is forming superficial to the vastus lateralis muscle. So if you follow the iliotibial band at the lateral aspect of the knee, it's going to come down to attach onto the anterolateral aspect of the tibia here at Gerdy's tubercle. It's important to know about the iliotibial band and the anterolateral corner structures, as these can often be injured in the setting of an ACL tear. Again, pathology will manifest as either edema surrounding the ligament, thickening or irregular intrasubstance signal intensity, or complete disruption. You can also get pathology between the IT band and the femoral condyle. So for example, in this region here, the iliotibial band can rub against the lateral femoral condyle, causing edema. This is a common finding in runners. So it's just another reason for you to be aware of this region here. Okay, so moving on to think about the extensor mechanism. This is formed of the quadriceps and patella tendons, which attach to the patella, and then the patella tendon distally will attach to the tibial tuberosity. So here's a quadriceps tendon attaching to the superior pole of the patella. You can see that the tendon has a laminated appearance. This is because it's comprised of 3 tendon slips, which are formed of the quadriceps muscles. The most superficial component of the tendon is from the rectus femoris muscle. Then this middle section here is going to be from the vastus lateralis and vastus medialis components of the quadriceps muscle. And then the deep aspect of the tendon here is going to be from the vastus intermedius muscle. So it's normal to see this striated appearance with some areas of interdigitating fat, which are these areas of gray or intermediate signal intensity. On the axial images, you also do get some interdigitating fat in the quadriceps tendon here, so you can see that horizontal fat that I showed you, but you can also see these areas of more perpendicular fat signal within the tendon. Again, that is a normal finding. This trilaminar, quadrilaminar, or laminated appearance of the quadriceps tendon is normal. A tear will have fluid, bright signal, loss of contour or loss of orientation, and then you might also lose tension within the ligament itself, within the tendon itself. Although if you can appreciate here, because the knee is in an extended position, the tendon itself is going to be lax. And then here's the patella tendon, which you can see is taut, extending from the inferior pole of the patella to the tibial tuberosity. Just a reminder that this bright signal we see here could reflect magic angle artifacts, and we tend not to call this a tear. We'll consider this a normal finding. Whereas if we see fluid bright signal, loss of contour, abnormal thickening of the tendon, or edema in the fat pad or overlying subcutaneous soft tissues, then we're more likely to call that pathology, whether it's tendinopathy or a tear. I always make sure to look at the extensor mechanism in the axial plane because you can see how broad these tendons are. So here's the quadriceps tendon contributions, and the same thing goes for the patella tendon. You can see how broad a structure this is. So you want to look at it on the axial plane to make sure that you're seeing the entire width of the tendon and not missing pathology, which is confined to a small component here. The patella tendon is of particular interest with orthopedic surgeons for two reasons. In some cases, this tendon can be utilized to reconstruct a torn ACL. Also, in some cases, if the tendon is too long, so you have developmentally lengthened patella tendon, you might be at risk for patella subluxation and patella dislocation. Two other structures to point out when you're thinking about patella dislocations. The medial patellofemoral ligament, which extends from the medial pole of the patella towards the medial aspect of the femur. So it's this structure here, usually thin structure, is called the MPFL, the medial patellofemoral ligament. And then as we head down towards the tibia, you can see these additional structures here, which are the medial retinacular structures. These are invariably torn in the setting of a lateral patellar dislocation, and it's important to make sure that you always assess these when looking at the knee. Okay, in the next section, we're now going to focus on the cartilage. Cartilage is comprised of a high water content and will be of intermediate signal intensity on the T2 or protein density weighted images. So I just want you to see that here. This is the bone marrow and cortex. This is a protein density non-fat saturated sequence. And you can see here the cartilage is not as dark as the tendons, but it's not as bright as the bone marrow, that intermediate signal intensity. And you can see the same thing here on the fat suppressed images. So here's the patella cartilage. You can see it's not as bright as fluid. It's not as dark as the bone marrow or the cortex. So intermediate signal intensity. So these two images on the side, the axial and coronal images, are protein density fat suppressed. And this is a protein density non-fat suppressed. It doesn't matter what sequence you're looking at. You can see the cartilage very well on all three planes. You can also see the cartilage pretty well on the T2 weighted images here, which are also fat suppressed, but I think you can appreciate that the distinction is better here on the protein density images. And this is really one of the reasons that we love this sequence very much in MSK MRI imaging. So looking at the patellofemoral cartilage, I think this is really well assessed on the axial images here. You can see the patella cartilage, which is the thickest cartilage in the body. And if you go all the way from the top of the knee, so on top of the patella, we're going to look at the cartilage on both the lateral and medial facets up until the inferior pole. And we're also going to assess the femoral trochlear cartilage. So remember the femur has a trochlear groove where the patella sits, and this will also be lined by cartilage. So we can see that all the way. We're going to scroll all through the images and assess the patellofemoral cartilage in its entirety from cranial to distal. I like the sagittal images for looking at cartilage because not only can you see the patella cartilage here, and you can scroll all the way from medial to lateral, but you can also see the femoral trochlear cartilage here. So this is the lateral femoral trochlea here. We'll go into the trochlear groove, through the groove, and then into the medial femoral trochlear cartilage. And we can also see the cartilage in the tibiofemoral joint, so all along the rest of the femur here and all along the rest of the tibia. And we're going to follow that cartilage in the medial compartment and all the way through on the lateral compartment. The coronal sequences will show you the tibiofemoral cartilage, particularly in the main part of the joint, but you don't appreciate these posterior aspects as well, and you don't see the cartilage in the patellofemoral compartment. Cartilage lesions will present as either a defect, maybe a fissure here, or abnormally increased fluid bright signal within the cartilage itself. The defects can be graded as mild, moderate to full thickness. And for now, the thing to be aware of is that the hallmark of a full thickness cartilage defect will be bone marrow edema-like signal alteration. So what do I mean when I say this? You'll have bright signal in the bone marrow adjacent to the cartilage here. So if you have a full thickness fissure that is going all the way to this bit of bone here, cortex called the subchondral bone, you're going to get reactive changes in the bone marrow. This might be true bone marrow edema, or sometimes the literature suggests that this may be due to increased vascularity as a remodeling of the bone. So this is why you'll often see the term used, edema-like bone marrow signal alteration. We're not sure if it's true edema versus vascularity, and that term encompasses both. In more chronic full-thickness cartilage defects, you might end up seeing a small, well-circumscribed cyst, and that usually tells you that the process has been going on for a longer time. Trainees often find grading cartilage defects challenging, and it's one of the more common areas that requires correction. We'll go through this in more detail in the case-based course. Some institutions will acquire gradient echo or a 3D sequence to assess the cartilage. More commonly, a gradient echo sequence will be acquired to assess for blooming artifact if you think there are intra-articular hemorrhagic products or calcific products, and we'll show you some examples of that. The rest of my checklist is focused on making sure that I don't miss subtle pathology. So I will now assess the bones looking at the bone marrow and the cortex specifically. Normal bone marrow is made up primarily of fat, so it will be of bright signal on the non-fat saturated sequences, such as on this PD sequence, and on the fat saturated or fat suppressed sequences, whether it's the T2 or the protein density images, that bone marrow fat will be nullified and will therefore be of low signal intensity. Cortical bone is made of densely packed bone with little to no fat and is heavily calcified, so it's going to be of low signal intensity on all the sequences available. The best sequence for assessing bone marrow and cortex is the T1 sequence, but this is not always available. So for example, in this set of images, we don't have a T1 sequence. So I'll use the information that I obtained from this non-fat saturated PD sequence, as well as the fat saturated sequences. The fat-saturated sequences will allow me to appreciate bone marrow edema really well, and then I can correlate that with the PD sequences here. So when you're looking for bone pathology, you might see a contusion, which will result in loss of the normal bone marrow signal and sometimes alteration of the contour. So if you think about the protein density fat-suppressed images here, for example, you might see bright signal and you might see some deepening of the cortex if you had a contusion. On the other hand, fractures will show similar loss of normal bone marrow signal, but you'll also be looking for a disruption in the cortex or linearity in that area of the bone contusion, and we'll show you some examples of that. This is important because certain injuries, for example, a lateral patella dislocation or a pivot shift injury with an ACL tear, tend to have a predictable pattern of contusion and bone marrow edema, and sometimes even a predictable pattern of fractures. You can also see bone lesions, and sometimes they may be just confined to the bone marrow itself, or sometimes they may be in the bone marrow, distorting the cortex as well. So it depends on what kind of bone lesion you have. So I just want to show you an example in this patient. You can see that there's this area of low signal intensity in the lateral femoral condyle. We can see that it's both low signal intensity on the protein density, T2 weighted, and the non-fat saturated sequences. So we know that this is not fat because it's not bright in this sequence. This makes us think that this is something that is calcified, and in a patient like this who has no other pathology and no concerns, this is most likely a bone island, which we would consider a normal variant. So next we're going to look at effusion here, and you can see that this patient has a small suprapatellar joint effusion, which is normal. For example, if the patient had walked to the department or had done some exercise, it's normal to see a simple appearing small effusion like this. I'm going to window the images here to just reduce some of the contrast between the fluid and this dark structure here, which is the synovial lining the joint. What I'm looking for is any areas of thickening or frond-like hypertrophy, which would be a surrogate marker for synovitis. I'm going to look at all the joint recesses. So this was the suprapatellar joint recess here. I'm going to look at the lateral joint recesses, the medial joint recesses, and also posteriorly, looking for the presence of any intra-articular bodies or any synovial pathology. So just to show you again on the sagittal images, this is that suprapatellar recess that we were looking at on the axial images, and you can see that there's fluid in it. And then medially here, this small volume of fluid here would be in the medial joint recess. This is a posterior joint recess. And if you go to the lateral side, this area of high signal intensity is fluid in the lateral joint recesses. Just to remind you that when I move on, I'll look at the popliteal fossa, specifically looking for that Baker's cyst. So just to remind you about what we spoke about earlier, this is the semimembranosus tendon here with this broad fan-shaped attachment to the tibia. Next to it is a medial gastrocnemius muscle. So you're looking for any cyst that is coming out between these two tendon structures, and that would be your Baker's cyst. But you can have other cysts at the knee. So for example, this is the popliteus tendon here, and you can see that there's a small volume of fluid here. Sometimes this can become more loculated as a proper ganglion cyst in the popliteus hiatus. You can also see smaller cysts at the medial and lateral gastrocnemius attachments. For example, in this case, we see these very commonly and we consider them within the remit of normal unless the patient is specifically tended there. This is also a good time to assess the popliteal neurovascular structures. So this is the distal third of the femur here. And you can see that there is this structure here which has a honeycomb appearance. It's sitting next to these two structures here. So this structure with a double wall here is the popliteus artery, and this is the popliteal vein. This is the sciatic nerve. So honeycomb structure here is going to be the sciatic nerve. As we descend through the knee, this is going to be the tibial nerve component here, which is going to descend medially. That's still that structure there. And I'm going to come back again just so you can follow that. And then this structure more laterally is going to be the common peroneal or common fibular nerve. And that is going to descend in the knee along the lateral aspect. You can see how very close to the skin surface it is, which is why this structure is easily injured if you have injury to the lateral side of the knee. This is it here again, superficial to the lateral gastrocnemius tendon. And then it's going to pass around the fibular head here before it disappears into the anterolateral compartment of the lower leg. Here it is again, and we're going to follow it back up towards the sciatic nerve in the distal aspect of the thigh. This is normal signal intensity for nerves, whereas when you have nerve pathology, you're going to get fluid bright signal. It starts to mimic joint fluid or fluid in the adjacent vessels. That will be abnormal. Sometimes you'll get abnormal thickening of the nerve, edema surrounding the nerve, and in rare or unfortunate cases, you can actually see complete disruption of the nerve fibers. I mentioned earlier the popliteal artery and vein. Routine knee MRI is not very good at looking at vascular structures, but you may still be able to see pathology. For example, if there was a large aneurysm arising from the popliteal artery, you may be able to see that outpouching. We're very poor at assessing the veins on a routine knee MRI. You would need a more dedicated study such as an MRV. But just to show you here, this is the popliteus vein. And here's a short saphenous vein, which is coming from the calf. So this is a short saphenous vein, and it's going to drain into the popliteus vein. There is another structure here, the posterior aspect of the knee, which is in very close proximity to this neurovascular bundle. It has a low signal intensity central component and a bright peripheral component. This is a lymph node, and we can see lymph nodes at the back of the knee. This is a normal finding. If they're abnormally enlarged or they've lost this normal architecture, then we may be able to suggest pathology. There are a number of muscles around the knee, which we've mentioned in passing before. These can be assessed for edema, for the amount of muscle or the muscle bulk, whether there's any fat within the muscles or if there are any masses. We won't go through the individual muscles in detail in the interest of time, but just to show you what normal muscle signal looks like. So the muscle will be of the same signal intensity or similar signal intensity on fat suppressed and non-fat suppressed images. So you want to see them as low signal intensity on all the sequences. These bright areas here are striated areas of fat, which you can see in most patients. But if you have excessive fat within the muscle or the muscle has reduced in volume, then you would consider that pathology. And remember, you can see muscles in the distal aspect of the thigh, but you can also see the calf muscles here. We have the gastrocnemius, popliteus, and anterolateral compartment muscles, as we'd mentioned before. There are three main fat beds that we can see at the knee. The quadriceps fat pad sits here superficial to the patella and just deep to the quadriceps tendon. Immediately anterior to the femur here, you have another fat pad here, which is going to be the prefemoral fat pad. And then inferior to the patella is this large fat pad here, which is Hoffa's fat pad. So on the non-fat saturated images, you can see those structures again here. So this is going to be Hoffa's fat pad inferior to the patella. In some books, you may see it called the infrapatellar fat pad. This is a quadriceps or the suprapatellar fat pad, which is this same structure here. And then this is a prefemoral fat pad. When these are abnormal, you may see edema, expansion of the fat pads, or you may even see masses within these. So that's what we would be looking for if you're looking for pathology. I finished my review by assessing the subcutaneous fat, which should be of uniform fatty signal. So on the fat suppressed images, it should be of uniformly dark signal. Any change in the signal could be due to edema, although in some cases you may get artifact, for example here, where there is suboptimal fat suppression. The way to check that is to see how far this extends, whether it's kind of in a straight pattern or if it's respecting anatomic boundaries. You can also see masses within the subcutaneous fat, for example, lipomas or tumors, or bursae, which are collections of fluid that develop to provide cushioning. It's normal to see subcutaneous vessels within the fat pad, but if these are enlarged, they can form varicose veins or varicose vessels, which can be symptomatic.
Okay, so now that you have an approach to knee MRI, it's time to take your skills to the next level with practice. First, I strongly suggest that you take the time to scroll through a knee MRI to identify all of these structures yourself, like the one available for free on our website with key anatomy labeled. The link is in the description. Next, our Knee MRI course on navigatingradiology.com includes a curated list of fully scrollable real-world cases, handpicked to efficiently teach you the key concepts you need to know. We gamify radiology by giving you AI-generated guidance and encouragement, interactive links to key findings, and concise teaching points. Thank you again to Dr. Angela Atinga for the excellent and comprehensive introduction, and we hope you enjoy the course. Thank you.